So, yeah. Thank you. So, question number one, without any further ado, first of all, apologies for not being there yesterday. Uh, I had a very hectic schedule. Sorry, very sorry. So today we'll finish it in an hour or so. We'll finish it so fast, and I'll see that you get all the points. Okay. So first question is during a radical neck dissection for metastatic laryngeal carcinoma, a surgeon carefully identifies the carotid sheath to prevent neurological function or preserve neurological function. The surgeon must be aware of the structures intimately related. Um, which of the following is located immediately posterior to the carotid sheath, embedded within the prevertebral fascia, rather than being a true content? So we are asking what is a content, what is not a content of the carotid sheath per se, but it passes just posterior. So what is the answer? What will be the answer? What is just posterior to the carotid sheath? What is just posterior to the carotid sheath? So if I see, if I draw it like this, so this is the carotid sheath. Okay, so I will have a colors. So this is this is the sheath. Okay, you have something like this. Yeah, thank you, Swati. Thank you. Very good, very good. You're right. You're right. So, well, something like this. So what are these actually? So these are the common carotid and the internal carotid artery, the vagus nerve, and the IJ. Okay, this is the ANSA, cervicalis, and this is the sympathetic chain. They are asking about this structure. What is this structure? This structure is nothing but is the sympathetic chain. Okay. Another interesting point is carotid sheath is contributed by its contributions from investing layer, pretracheal, and prevertebral. Okay. Just to add on, I know that you all know this, but still, just to add on, what are the areas devoid of deep cervical fascia? One is space, except the parotid gland. And then we have the anterior abdominal wall. Okay. What are the modifications modifications of deep cervical fascia? So the modifications of deep cervical fascia are, first one is the investing layer, Then you have the pretracheal. Then you have the prevertebral. Then you have the buccopharyngeal fascia. And you have the pharyngo basilar fascia. Very important. Okay, very important. Moving on to the second question. Arrange the following as per the steps of ventricular action potential in the correct order. So, first you have the phase zero of rapid depolarization. So, depolarization we told sodium channels open. Okay. Then you have the initial repolarization where there is transient potassium outflow. Then you have the plateau phase where L-type calcium channels open. Okay. Then you have the repolarization where potassium outflow occurs. And if we go according to the order will be C, D, A, B. C, D, A, and B. If they ask you the ions in the order is sodium, potassium, calcium, again potassium. Okay, this is the order of the ions. Okay, the long plateau phase prevents the tetany of the cardiac muscles. 42-year-old woman presents with a 3-month history of early satiety and dyspepsia, diffusely thickened and rigid stomach. There's Linitis plastica. Okay, it is also called as signet cell carcinoma. Okay, I hope you are signet ring cell carcinoma or leather bottle stomach. All these are one and the same. Okay. Which of the following statement is most accurate regarding this patient's condition? Okay. So what happens here? There is E-Catherine loss. E-Catherine loss system. Okay. And there is CDH1 mutation. Okay. So what happens there is poor cell adhesion and there is diffuse infiltration of the stomach wall. First option is it is inherited. No, it is not inherited. Instead, it is sporadic. Second option is the underlying pathogenesis involves a defect in cell-to-cell adhesion molecules. Yeah, that is true. E-cadherin is an adhesion molecule. Third one, defect in WNT signaling pathway. No, it's not WNT signaling pathway. Okay. A WNT pathway defect is seen in intestinal type of the gastric cancer. Then they say depth of tumor invasion is not a significant prognostic factor. It is the most important in TNA. Okay. So the answer will be this one. Okay. Next question 4. 48-year-old male with a history of severe alcohol use disorder is started on Disulfiram by his psychiatrist to support his goal of complete abstinence. Patient is highly motivated and has a supportive spouse. The psychiatrist counsels them about the medication. which is true and should be a part of the reaction. Okay, so the the key of the question is to understand the mechanism of action as well as the counseling points in case of disulfiram. Okay. So nowadays they ask a lot of questions from these addiction psychiatry. De-addiction psychiatry has become a separate branch in like DM addiction psychiatry. So so it is very important. Okay. So what is the mechanism of action? It is the inhibition of aldehyde dehydrogenase. Okay. So alcohol intake will lead to increased acetaldehyde and hence disulfiram reactions. Okay. Does it reduce the craving? No, it does not reduce. Instead, which drugs reduce the craving? It is naltrexone or acamprosate. So acamprosate used to be a very favorite question, right? Because the dose of the drug was 333 milligram, 666 milligram. That is the dose of the drug. Now they don't ask that one. Okay. So second one is consuming alcohol while which cause an unpleasant reaction. Exactly. That is what. Okay. Like, alcohol causes flushing, headache, nausea, dyspnea, palpitations. Hence, it is used as a deterrent therapy. Okay. Then they say it is a safe first line option even for patients with low motivation to quit. No. Patient needs high motivation and supervision. High motivation and supervision is needed. Okay. Then the effect is long lasting. Even after stopping the drug, the patient can develop disulfiram like reaction. Hence, the answer is 2 and 4. Okay, question number 5. Vitamin K dependent gamma carboxylation of glutamic acid residues is required for all of the following except one. Okay, so what is the question? Which protein does not require vitamin K dependent gamma carboxylations? Okay, what are the proteins requiring vitamin K dependent gamma carboxylation? You have a clotting factors. Which are clotting factors? Clotting factors, they are. What are the clotting factors? Can somebody tell me? Which clotting factor? Vitamin K dependent clotting factors? Someone? Anyone? No one? Or is it like people started leaving because, oh yeah, perfect, Arun. Perfect. Thank you. Thank you. Thank you. Perfect. It is 2790. Thank you. Hi, Vaibhav. I didn't see you. I was about to ask where you were. Is Gaurav here? Gaurav joined. Hello, Gaurav. Are you there? I can see. Gaurav, are you here? Yes. Okay. Thank you, brother. Yes, yes, Arun. Yes. So Arun has responded. Arun doesn't want me to deviate from anything. 2, 7, 9, 10. And what are the regulatory proteins? The proteins are protein C, protein S. Sorry, protein C and protein S. What are the bone proteins? Osteocalcin. Yeah, very good. Osteocalcin. Okay. You will see this protein C, protein S somewhere else also. What is, where do you see that? Where do you see protein C, protein S? Okay. You see it in hypercoagulability. Yeah, warfarin. Hypercoagulability. Yes. The inherited cause. Yeah, yeah. Warfarin toxicity, you see this protein C, protein S mutation. Then another important one is factor V or factor 5 Leiden mutation. So the answer is antithrombin 3. Okay. Next question. Identify the injury shown in the figure. So the injury identification, it is actually a um, any wound on the scalp, on the eyebrows, or the shin. Okay, always suspect something called as incised looking lacerated wound. Okay, what is the mechanism of injury here? There is a blunt force over a bony area. Bony area. Now, question number 7. Twin fortified salt contains, it is just a like fact-based question. It is iron plus iodine. Iodized salt with iron fortification. This twin fortified salt. Why? Because it prevents goiter as well as iron deficiency anemia. Okay. So this is also used in midday meal program. Okay. Next question is question number 8, where you say a 28-year-old female is brought to the ENT clinic by her husband. I'll underline the major headings. Okay. One is foul odor from her nose. Okay. Who is noticing? It is by the husband. Okay. Then patient unaware. Okay. And complains of a constant feeling of nasal blockage. Okay. Then they say there are roomy nasal cavity. Okay. And there are greenish yellow crust and abnormally roomy nasal cavity. Okay. So what is the diagnosis? It is nothing but Ozina or atrophic rhinitis. Okay. Ozina or atrophic rhinitis. Okay. Very important question. Very important area they ask questions now. Okay. So what is this? What are the other key points you look for in this question? You'll be having merciful anosmia. The other question that we can ask is, what is the treatment? So the treatment is, let me go and write it down. Treatment of atrophic rhinitis. Okay. Ideally, this is not the order, but still I'm writing in a half a order. What are the surgery? What are the surgeries done? And you have the Young's operations. Yes, very good. Very good, Walter. Young's operation. And then you have the modified Young's operation. So in Young's operation, what do? You do a complete closure. Whereas in modified, you do a partial closure. These are the surgeries done. Okay. Now, what are the antibiotics given? with the antibiotics given. Antibiotics given are the COPD. What is COPD? COPD is chloramphenicol, estradiol, propylene glycol, and vitamin D. Okay, so this is called as chemisettin solution. Okay, then you have alkaline dowsing. How do you do this alkaline dowsing? You do sodium chloride plus soda bicarb plus sodium biborate in the ratio 2:1:1 in distilled water. So this is alkaline dosing. Okay. Hope this is clear. Hope this concept is clear. Okay. Atrophic rhinitis is a very important area. That's why we discussed this much. Question number 9. What is defined as moderate to severe? Oh, so what is the most common cause of moderate to severe visual impairment? Oh, nothing. It is untreated cataracts. So refractive error is the most common cause of visual impairment overall. Overall. What about glaucoma? It is the important cause of irreversible blindness. Okay. Okay. Whereas a reversible blindness, it is cataract. Okay. And this is the most common correctable cause. Okay. That's it. Now question number 10. Question number 10. We say 70-year-old man brought it by in his family due to a gradual cognitive decline. So there is a progressive cognitive decline with history of hallucinations. Progressive cognitive decline plus hallucinations. Okay. And there is a classical thing where you have prosopagnosia. What is prosopagnosia? Inability to identify familiar faces or similar faces. Okay. The dominant feature here is progressive memory impairment. Okay. And here you have auditory hallucinations. So this is the one DD that you will fall for, LBD. But in LBD, there will be visual hallucinations. Okay. And they are very prominent and early. Okay. And you will also get a fluctuating cognition. Okay. What about late onset schizo? There is no progressive cognitive decline pattern in schizo. Okay. And FTD, there will be early behavioral changes as well as personality changes. Okay. So that is it. Just a minute. Okay. So the answer is Alzheimer's. Okay. Now- okay. Question number 11. Okay. Now they have bacteriological index of 3 plus with a classical inverted saucer appearance. So what type of leprosy is this? What type of leprosy will this be? Somebody? Anybody? Nobody? Everybody? Excellent. It is borderline BV. Okay, borderline. And this is actually the Ridley Joplin classification. So why is it not BL? Borderline lepromatous. More patients and more symmetric and more bacteriological index. Why is it not BT? If it was BT, there would have been a classical severe sensory loss, which are well defined. If it was lepromatous leprosy, it would have been symmetrical and no sensory. Video. Question number 12. Okay. Question number 12. Lumbar puncture, which is the next layer after the dura. Very easy. The next layer after dura will be arachnoid matter. So just to have a recap of the structures pierced during lumbar puncture, structures traversed in lumbar puncture. Very important. So the structures are in the order skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. Then you have the epidural space. Then you have the dura mater. Then you have the arachnoid matter. Then you have the subarachnoid space, where you get what is called as the CSF. Okay. Very important. Okay. And what do you feel? Another question they ask is, what does the feel? They get a pop when they get a dual function. Okay. Now, moving on to the next question. Question number 13. STI clinic vaginal discharge. So, vaginal kits has already been discussed. So, vaginal discharge, the kit will be green. Okay. Next question. Question number 14. What do you have? You have a classical fallen fragment sign. And you have a metaphyseal. Okay. Oh, cervical erosions are also present. Why not break it? Okay. Okay. So the question needs to be discussed. So see, now the question is, patient has minimal vaginal discharge with cervical erosion on examination. Okay. So cervicitis is most commonly is due to two organisms. One is gonorrhea and chlamydia. So to treat both these things, what will we do? We give the green kit. Okay. The antibiotics will be cefixime plus azithromycin. So I think 2023 NEET PG, they had a number of questions from this syndromic management of vaginal discharge. Okay. So very important. So at times they show some, like, what to say, they show some so they show some interest towards some topic or the other. For example, one year they showed much interest on vitamins. They were already asking vitamins every day. Four or five questions were asked from vitamins. Okay. So we have a fallen fragment sign, which is classical of SBC, simple bone cyst. Okay. So simple bone cyst or unicameral bone cyst. Okay. There will be a fluid filled cavity seen in children and adolescents. Okay. Mostly in metaphysis of long bones. And that too, proximal humerus is the most common. Okay. If it was ABC, it would have been another soap bubble lesion. If it was GCT, it would have been in the epiphysis with age between 20 to 40. And Ewing sarcoma would have been in the diaphysis. Okay, and there would have been onion skin periostal reaction. Question number 15, HRCT of the female with the history of fever, expectoration, difficulty in breathing. Okay, so what do you see here? You see air bronchogram. Okay, what do you see? Air bronchogram, which indicates a infective lung pathology. Consolidation. Okay. So even the surrounding alveoli is opaque. There will be black branching pattern. Bronchi. Okay. I hope this is also clear. Okay. Another CT they can ask is ground glass opacities. Sin COVID. GGO. Ground glass opacities. Okay. Now question number 16. Okay. Question number 16. 65-year-old. Nothing. This is another repeat question. Chronic gout prophylaxis. So we had already discussed drugs for gout. Okay. Acute gout and chronic gout. So long-term prophylaxis for chronic gout, the drug of choice is allopurinol. Question number 17. Question number 17. 43-year-old male with a history of chronic alcoholism, 5-day history of high-grade fever, dull aching pain in the right hypochondria. Okay. So what is the diagnosis? There is a bloody diarrhea, marked tenderness over the liver, ultrasound image is not shown. Oh, I'm sorry. Okay. So ultrasound image was not given, na? Did you see the ultrasound? Was it given? Oh, it was given. Okay, sorry, I think this is clear. Okay, so the typical um, finding will be there will be a hypoechoic lesion, round or oval in shape. Okay, okay, same in the usually in the right lobe of the lung. Okay, so the diagnosis is amebiasis, extra intestinal amebiasis. Okay. The standard treatment would be giving metrogel or metronidazole. Next thing is when to drain. When do you drain this patient? When do you drain? when there is a large abscess, and there is a left lobe, left lobe abscess, when there is a risk of rupture, when there is poor response to drugs. All these conditions we need to do drain. So it is percutaneous drainage combined with medical management. Okay, question number 18. 67-year-old male, non-smoker, hypertensive, diagnosed with as asymptomatic infrarenal abdominal aneurysm. Okay, now the question is when to operate in case of a what is the threshold for elective repair? Very important. The threshold for elective repair is more than or equal to 5.5 centimeter in men. Okay. Then, if there is rapid expansion, if the patient is symptomatic, if it is less than 5.5 centimeter, then just observe. What you need to do, you need to do a regular ultrasound follow. Okay. So, abdominal aortic aneurysm more than or equal to 5.5. Okay. Question number 19. A 16-5-year-old man presents with drooping the right eyelid, the right dilated pupil, which is non-reacting to right, inability to move his right eye upwards, downwards or medially, pose intention tremor and ataxia in his left arm and leg. MRI show a lesion affecting a fiber tract, decussation at which level? So we see a classical Weber syndrome. What is Weber syndrome? Weber syndrome is a lesion, okay, which involves the oculomotor nerve, the cerebral, yeah, very good. Third nerve, I see. Cerebral peduncle and the retinonucleus pathways. So you have a crossed neurological deficit. Crossed neurological deficit. And hence the answer is midbrain. Okay. So the answer is midbrain. Very important. Okay. Okay. I hope you all know the midbrain syndromes and all. I will not elaborate. No? It's very much aware to everyone. Should I elaborate? Should I tell the midbrain syndromes or the localization? Yes. Oh my God. Okay, I wasn't prepared for this. But yes, okay. 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 So I'll write in fast. Okay. So if you have contralateral hemiplegia, okay, and you will have ipsilateral down and out pupil. What will be the diagnosis? Then you have contralateral hemiplegia with cranial nerve 6 plus 7. You have contralateral hemiplegia plus cranial nerve 6 plus 7 plus hemisensory loss plus 6 plus 7 plus 8 plus INO. Okay. Then you have contralateral hemiplegia plus ipsilateral sixth nerve palsy. What are these? Okay. This is Weber. This is Millard Gubler. So Millard Gubler, I counted the number. Okay. So Millard has 7 letters and Gubler has 6 letters. So cranial nerve 6 plus 7. Then 6 plus 7 plus 8. The 3 combination comes and I know it is 4 will. Okay. 6 ipsilateral, it is rain. Okay. You have Claude, Benedict, and all. Okay. So where do you get Claude? If it is Claude, and if it is Benedict. Okay. So if it is Claude, then you will get contralateral hemiataxia plus hemi-hyperkinesis plus chorea plus tremors that are hyperkinetic disorders, then ipsilateral down and out. Similarly, ipsilateral down and out pupil with chorea tremor, contralateral. Without ataxia is done. Okay, that's it. Question number 20 already discussed previously. It is arachnoids. Empty. Okay. Is this clear? Is this clear till now? Is 20 questions clear? Are these 20 clear? Yes, yes. May I go very fast in 15-20 minutes? May I go? Please show the midbrain section. Bro, I haven't put it, bro. I'm sorry. I'll put it. I'll put it. Okay. I'll show it the next step. So, the points I just showed. This one. Go slow with full explanation. Okay, brother. Okay. ठीक है. Okay. So question number one. Question number one. Questions 20th one. Bro, it has already been discussed. The recorded classes will be available. Okay, bro. You will get it. Okay, Samir. Question number one. Which of the following structures is not covered by pretracheal layer of deep cervical fascia? So the pretracheal layer of deep cervical fascia covers the thyroid, trachea, esophagus, and the strapnosis. This much. Okay. Okay. So The answer is sternocleidomastoid. Okay. So pretracheal fascia has a muscular part and a visceral. The muscular part covers the sternohyoid and the sternothyroid. And visceral part the trachea, thyroid, and the esophagus. Okay. Sternocleidomastoid is covered by the investing layer of deep certification. It surrounds SCM and trapezius. Investing layer has actually the rule of two. What is it? Two muscles. Okay. Then you have two spaces. Then you have two glands. Then you have two ligaments. Okay. Then you have two pulleys. Very, very commonly. I think you know all this. And just to revise, two spaces, the suprasternal and the supraclavicular. Two glands, the submandibular and the parotid gland. Two ligaments. What are the two ligaments? The stylomandibular and the sphenomandibular. Forms two pulleys. Where are and the omohyoid and then the digastric muscle. Okay. Now, question number two. A 6-year-old boy weighing 20 kg is scheduled for circumcision surgery. Which of the following will be the best for ventilation? So, now, very, very commonly asked question, but now we don't see much of these circuits and all. Okay. I don't know why. They have stopped asking these circuits and all. But still, Mapleson circuit is a very important area. So, Mapleson circuit, I hope you all know. No? It is a semi-closed circuit. It is a semi-closed circuit. Okay. Mapleson C and Mapleson F. C has a corrugated tube. What is a corrugated tube? Corrugated tube is a no, C doesn't have a corrugated tube. What is a corrugated tube? This is the tube. C. This is the corrugated tube. C doesn't have corrugated tube. And F is the F doesn't have a ATL. Okay. ATL is the adjustable pressure relief valve. Okay. So C and F. F is also called as Jackson Bruce. Yeah. Jackson Reeds is actually a modified ISTPs. It's a modified ISTPs. Okay. What is B? It is a modification of Maples and D. It is for adults and high flow. ISTPs, there is no reservoir band. And what is Magil circuit? It is for spontaneous breathing in adults. Okay. Question number 3. Question number 3 says 48-year-old man with a BMI 34. Now, they are asking about the insulin signaling defect. Okay. Now, they are asking a type 2 diabetes mellitus or an insulin resistance case. And where will the defect be? The defect will be in the post receptor. Yes. Okay. What happens normally? Normally, insulin binds to the receptor or the alpha subunit. Then in the beta subunit, there will be tyrosine kinase activation followed by intracellular signaling cascade pathway. Signaling cascade followed by GLUT4 vesicles move to cell membrane followed by glucose entering the cells. Okay. So what is the defect here? Binding is normal, but tyrosine kinase activation is also normal, but there is GLUT4 translocation damage into decreased glucose uptake. Okay. So there is GLUT4 failure. Very important. Okay. Question number 4. Question number 4. Patchy hair loss with itching and erythema shown in the figure. So, what is it? This is a classical picture of tinea capitis. Okay. There is patchy hair loss with itching and erythema. Okay. So there is patchy hair loss with itching and erythema. Okay. So this is a fungal infection, and hence you could do a slit skin. Then hence you should do a KOH stain. Okay. What does KOH does? KOH dissolves the keratin and leaves behind fungal. Okay. The slit skins here it's used for leprosy. Gram stain is used for bacterial infections and biopsy when there is unclear diagnosis. So next common thing is what are the 3 things? You have dermatophytosis. Dermatophytosis. They have irregular branching. irregular branching. Okay. There are three: microsporum, trichophyton, and epidermophyton. Okay. Okay. Now we have skin, hair, nail. In trichophyton, just tri. So all are affected. In microsporum, N is not affected. And in epidermophyton, hair is not affected. Will not affect near and dear ones. Okay. Very important. Now, question number 5. Question number 5 was actually discussed in the Calicut group yesterday. So, Rokitansky is in situ. Okay. Verco is Verco 1 by 1. 1 by 1. Or organ by organ. Gone is en bloc. Okay. And lectule is en mass. Okay. Very important. Very important. Kindly go through this. Okay. Types of autopsy is very important. Question number 6. Okay, question number 6. Now, what is the least helpful thing in identifying cluster headache versus trigeminal neuralgia? So, this is actually a history of a cluster headache. Why is it a cluster headache? Because it is a severe unilateral periorbital pain with very frequent attacks. Like they say more than 50 per day. Okay. And these attacks last for very short duration, approximately 45 seconds, and associated with redness and tearing. Okay. So, which is least common to both? So, it is the stabbing character. Because lacrimation, conjunctival injection, nasal congestion, these are absent in trigeminal neuralgia. So other name of trigeminal neuralgia is actually tic doloro. Tic doloro. And the drug of choice is carbamazepine. Carbamazepine. Okay. Very important. Do you know the approach to headaches? Should I say that? Approach to headache? Does everyone know? Should I say? Should I say? I don't think anybody needs that. Okay. We'll move to question number 7. You know the approach to headache, na? I mean, not that. Okay, we'll move on to the next question. Question number 7. Revise approach. Array. ठीक है. Okay. 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 So because the next question is also approach to headache, we'll go with that. Okay. Okay, Gaurav. Okay. So approach to headache. So headache can, how will you approach? It can be unilateral or bilateral. Okay. When it is unilateral, when you have pulsating unilateral migratory. Sir, if you are comfortable in Hindi, you can teach in Hindi too. No, 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 I'm comfortable in English. TK and all is coming because I am at Kolkata. I'm very comfortable in Malayalam. Hindi also I am fine, but I don't think everybody can follow Hindi. Okay, so pulsating, unilateral, migratory, and with aura. With or without aura. Samir. ഞാൻ മല്ലുവാണോ ഇല്ലാന്നൊക്കെ ഹായ് മോനെ. So it is migraine. Okay. When you have a male with 15 minutes to 3 hours duration, mostly it will be cluster. When you have 5 to 20, 200 seconds with burning, stabbing pain, it will be short-lasting, unilateral, neural deform headache with conjunctival injection and tearing, also called as shunt. Okay. When you have pain for 5 to 200 seconds with involvement of trigeminal 2, 3, which is triggered by chewing or touching, it will be trigeminal neuralgia. When it is bilateral with the dull aching, papilledema, diplopia, and history of tetracycline, obesity, danazol, and vitamin A excess. You call it pseudotumor cerebri. Cerebri. Oh, what is shunt? No. Short lasting, unilateral, neural deform, and with conjunctival injection. Yeah. Okay. Okay, Valsa? Video. Intra. Then you have a band 4 to 6 months. It will tension. Tension headache drug of choice will be NSAIDs. Prophylaxis. PCOS. Okay. When it is cluster headache, drug of choice will be 100% oxygen plus triptan, and prophylaxis will be verapamil. Okay. Okay. Question number 7, 45-year-old. Okay. So now they are asking what is the management of acute episode of a cluster headache. Okay. Question number 8, 65-year-old man from rural Korea. Oh, Korea. Sorry, 3 month step. Okay, so similar question we did. Okay. Just cholangiocarcinoma. Why is it cholangiocarcinoma? There is a history of raw freshwater fish eating with endemic area. And the patient has features very good. It is nothing but the causative organism is Clonorchis sinensis. Clonorchis sinensis. So, bladder carcinoma is schistosoma. Question number 9. Very easy question. Okay. Substrate available in the concentration that is 1000 times the Km value. So this immediately means that the rate is directly proportional to the enzyme as it is 0 order. Hence, substrate concentration is equal to 1000 times the Km that is given. Okay. Now, initial time is 9 and the product is formed the same. So, the enzyme is decreased to 1/3. Okay. So, new rate will be 1/3 of the original. And they are asking the rate is becoming 1/3. Okay. Rate is becoming 1/3. So, time becomes 3 times. Okay. As rate decreases, time increases. Okay. So, with new time will be 9 into 3, which is equal to 27. Okay. Question number 10. Okay. Eye drops versus ointment. Okay. Correct answer is you should first instill the eye drop and then wait at least 10 to 15 minutes and then apply the oil. Okay. Very important. This is a PYQ. Okay. If you apply a ointment first, then ointment will cause a film barrier. Okay. Now, question number 11. There is persistent pain after oris. Okay. So, what is it? This is the classical history of a aseptic non-union or mechanical failure. Why? Because oris was done 9 months back. and there is persistent pain at the fracture site, okay, with normal ESR therapy. This itself rolls out. There is no infection. Okay. The best management will be revision or now, question number 12. Pathologist is evaluating several tissue samples, which is most characteristic of dystrophic calcification. So, dystrophic calcification, dystrophic calcification. What are the features? Because dystrophic is usually seen in dead tissues. Okay. Some of them, yeah, very good. What is the stain for calcium? Stain for calcium. Yeah, very good. This is the von Cosa stain. You can use the von Cosa, or you can use alizarin red, or you can use calcium, or you can use Avans. So, in dystrophic calcification, which will be in the dead or degenerating tissues with normal blood calcium levels. Okay. Examples are monkey bug sclerosis, where you will get medial calcific degeneration. Happens in the tunica media. Okay. And there you will get Samoma bodies. Samoma bodies are always seen in all papillary cancers, papillary carcinomas. Then you will get prolactinoma, then seminoma, serous ovarian tumor, meningioma, mesopelioma, all these conditions. You get a dystrophic calcification with the Samoma bodies. So, disorganized bone in and increased ALP. What is this diagnosis? It is nothing but Paget's disease. Non-calcific grandomas plus calcific deposition in the kidneys. This is actually due to hypercalcemia and it will be metastatic calcification. Now they say again metastatic. Okay. Okay. Next question. Question number 13. Okay. 12-year-old girl with a 6-month history of battling gait and progressive dull aching pain in both hips. On examination, several large flat hyperpigmented macules are seen. What are these? These are actually cafe ole spots with irregular jagged borders called as the post of name. Okay, so you have McCune Albright syndrome. Okay. What is the classical triad? One is polyostotic fibrous dysplasia with cafe au lait spots and endocrine is like precocious puberty. So, see the fever? There is ground class appears. Okay, so if it was NF1, it would have been cost of California. That is regular borders. In LCH, you won't get any cafe au lait. Question number 14. As per the latest NRP guidelines for a non-vigorous JV, PPV should be initiated promptly if apneic or heart rate is less than 100 beats per minute. Okay. In earlier practice, there was this routine suction, mouth followed by nose and all. Now it is all ruled out because now the focus is on ventilation and not on suction. Wait, question number 15. NRP, you can expect a question, okay? One question. Now, yeah, this is also already discussed. Advanced Directive, Mental Health Care Act. So, Advanced Directive is a legal document in which a person can state how they want to be treated in future, or he specifies what treatment to be accepted or refused, and he appoints a nominated representative. Okay. Why is it advanced? Because everything has been decided in advance. Now, question number 16, effects of salbutamol, which is the least to be expected. Okay. So, salbutamol is a beta agonist, which causes increase in CAMP and it causes bronchodilation plus metabolic and systemic effects. So it can cause hypokalemia, tachycardia, tremors, and hyperglycemia, but never hypoglycemia. Okay. Next question, 32-year-old pregnant lady, 32 weeks gestation, presents with newly developed hypertension and proteinuria. So what is the mechanism of preeclampsia? Very important area. They are asking the mechanism of preeclampsia. So during normal pregnancy, the extravillous cytotrophoblast will invade the maternal spiral artery and transforms them to dilated, low resistant vessels, thus ensuring adequate placental blood flow. But then there is preeclampsia, there is inadequate trophoblastic invasion. Inadequate trophoblastic invasion leading to spiral arteries remaining narrow and high resistance. Okay, so there will be placental ischemia. So we say there is the second wave of trophoblastic invasion. Okay, now question number 18. Which of the following is not a specific protection method under primary prevention? So levels of prevention is another important area. Okay, levels of prevention: primordial, primary, secondary, tertiary. Okay, primary prevention has two components. One is health promotion and specific protection. So specific protection will handle all the specific diseases like vaccination, nutrient fortification, chemoprophylaxis. All these come under primary prevention. Okay. So rifampicin for conductive leprosy, chemoprophylaxis, specific protection. Wheat flour fortified with iron. Yes, specific protection. Vaccination, specific protection. So what is the answer? Health education. Okay. Question number 19. 19 says 34-year-old strict vegetarian, iron deficiency anemia. So which increases absorption of vitamin? No, which vitamin increases the absorption of iron? So iron absorption is increased by vitamin C. Okay. Whereas phytates, tannins, tannins, that is T, calcium, all these decrease iron absorption. Whereas vitamin C, the gastric acid, is increased this iron absorption. Last question, which is the diluting segment of the kidney. The diluting segment of the kidney is the thick ascending lobe, TAL, thick ascending lobe of the, as it is impermeable to water and It actively reabsorbs sodium, potassium, and chloride. So as a result, what happens? Solutes go out and water stays. This tubular fluid becomes dilute. Hmm. In PCT, fluid is isotonic. In collecting that, there is variable permeability. Why? It depends on ADH. In descending loop of Henle, the fluid becomes concentrated. Why? As it is permeable to water. Okay. So that's it. Thank you. I think I took 1.5 hours for this question, 40 questions. Sorry. Thank you. Good night. Hope it was useful. Okay, Samir. Okay, Gaurav. Good night. Thank you.